Okay, thank you very much, Dr. Peller, and thank you for your guidance all through your mentorship. So after Dr. Cordora and Dr. Peller took us to advanced therapies, I'll take you a little bit behind to conventional therapies. And those are my disclosures. And what do we mean by conventional therapies? Conventional treatments, okay, so we don't, oh, it's here, okay, it's fine. Okay, so conventional therapy is usually defined as the treatment that widely accepted or used by a physician. And I don't really think that what we mean by conventional therapies in psoriasis, because that will probably include biologics. Whenever we talk about conventional therapies, we mean those older therapies before biologics and small molecules. And here I wanted to show you that we still use conventional therapies, but already Kelly provided a good introduction. So I want to share with you this study from the Netherlands, who studied pediatric psoriasis patients over 10 years. And interestingly, they found that 62.3% of patients stayed only on topical treatments, while only 14.3% switched to phototherapy, and 23.4% were switched to systemic treatment, including methotrexate, fumaric acid esters, cyclosporin, and retinoids. And interestingly, the median time for the patients from the psoriasis onset until discontinuation being only on topical treatment was 7.3 years. So on the ground and in practice, we still use conventional therapies a lot, whether topical or systemic. This is the list of the conventional therapies we have, whether topical or systemic. We will pass through them, but let me show you first this table from this article about the off-label uses of psoriasis. Here is a list of the conventional therapies, and as we can see that almost none of them is approved in pediatric psoriasis, neither by the FDA nor by the EMA. And that's because we have limited data and studies in pediatric populations. So what we do, we had this discussion yesterday, and we base our decisions on the guidelines in adults or in the use of these medications in other pediatric diseases, like the use of calcineurin inhibitors in atopic dermatitis and the use of retinoids in ichthyosis and so on. But of course, the off-label uses of these conventional therapies, we all use them, and this make the therapy of pediatric psoriasis even more challenging. So let's go through them. I will highlight the most practical point with each one, starting by the adjuvant treatment, starting by emollients and urea. And we all use emollients adjuvants to treatment even if the patient are on systemic treatment. They decrease pruritus, they can decrease the irritation from other active treatment, and they are basic skin care, they are safe and can be used at any age. Moving to the next adjuvant, and in the next 3 topical treatment, we'll be talking about the problem of systemic absorption with topical medications. As we know that in children and infants, they have larger surface area, and therefore we have problem with some topical treatment about the systemic absorption that can lead to side effects. Salicylic acid is, as we know, is a keratolytic, so it's used with thicker, scaly plaques. It can be used as adjuvant, sometimes compounded with steroids or used by tar. The main side effect is percutaneous salicylic intoxication from systemic absorption. So the recommendation is to use above 6 years of age better and not use in a large body surface area more than 20%. This is a table from the German Society of Dermatology showing the recommendations regarding the concentrations, the body surface area, and duration of use of salicylic acid in each age group. Moving forward to the topical specific active medication, starting by topical steroids. We all know, like in adults, they are the first line therapy, and we are aware about the local and systemic side effects and tachyphylaxis. And for ultra-potent steroids for children, as we know, we need to use them for short time. Moving to the next, and that's topical vitamin D3 analog. And in practice, topical vitamin D is used as a first-line treatment combined with topical steroids like in adult. This combination is approved by the FDA above 12 years of age, but of course we use it off-label at a younger age. The main problem with systemic absorption is hypercalcemia, particularly with younger children and with larger affected surface area. So the recommendation that we shouldn't use it under occlusion with large surface area. Body surface area should not exceed 30%. And we need to be cautious in patients having disorders of calcium metabolism or renal disease. Next come calcineurin inhibitors, and as we know, they are effective, particularly in the face and in the intertriginous area. They are generally safe. We use them off-label. This age recommendation is from atopic dermatitis, but of course they are safe, and we usually use them at younger age. Last but not least is tazarotene. And what's important here about tazarotene is its use in nail psoriasis. There are studies in pediatric psoriasis, in adult psoriasis, about the use of tazarotene in nail psoriasis, whether it's a nail matrix disease or a nail bed disease. It's usually combined with topical steroids, either of them on one application, to be applied to the nail bed, the nail fold, and periangular skin. And it was reported to be as effective as early at 8 weeks of treatment. So this can be an option for treatment of nail psoriasis if we don't want to use systemic treatment or even combined with systemic treatment. The main side effect of tazarotene, as we know, is irritation. We usually use in short contact, and we use it off-label, but the FDA approval is above 18 years in psoriasis and above 12 years in acne. That's about active treatment. Let's move to the second-line therapy, and starting by anthraline. There are some studies about the use of anthraline in pediatric psoriasis, but let me check in the room here how many still use anthraline in their country for pediatric psoriasis. Anyone? No one used anthraline. Oh my God. Okay. So sometimes you use it still in Europe. Anthraline has moderate efficacy. So sometimes it works, sometimes it does not. So sometimes it works a trial. It's considered a second-line treatment before starting systemic treatment. The main side effects are staining and irritation. Otherwise, it's safe. It has negligible systemic absorption. It's commonly used as short contact, and from the German Society, it's recommended to be used above 1 year of age. And I don't know if I can ask about the topical use of TARs about other than shampoos. Okay, so I didn't expect that. I expected some were use anthraline more. So, I want to remind you that TAR is the older aryl hydrocarbon receptor agonist before tapinarof. In some countries now, I think many of you raised the hands, it's mainly for being shampoos and used as shampoos in scalp psoriasis. But in some countries, like in my country, we still use it as a topical treatment. TAR is effective, actually. It's more effective than anthraline. It has relatively low cost. It has a steroid-sparing effect, and it can be used in individualized cases, particularly in resistant thick cases. The main problem is staining. It's more staining than anthraline, and the odor. And of course, the kids really hate its odor. It's also irritant, and there is a risk of chromosomal aberration, and therefore is avoided in areas where we don't like to have irritation and contraindicated with history of carcinoma. And interestingly, there are no studies in the literature about the cold tar monotherapy in pediatric psoriasis, but what the off-label use come from the combination of tar with UVB, that's called Zuckerman treatment. I think this has been historical in many countries. It's still used in some countries. The prolonged use carry the risk of carcinogenesis too, so whenever it's used in some countries, it's usually used for selected cases with close monitoring and for short duration, and we need to shift up to another line of treatment. Going to systemic therapy, and of course I won't mention phototherapy, Fernando already covered it fantastically, but before we're talking about systemic therapy, I want to highlight to have effective topical treatment, we usually need to use treatment in combination and in rotational therapy. These are the topical synergistic combination. We already mentioned them during our talk, and there are some topical combinations that we need to be avoided. We can combine the same application, an emollient containing zinc oxide with salicylic acid or anthraline, because it will cause inactivation of both drugs. And we can combine in the same application a compound containing salicylic acid and calcipotriol, because salicylic acid will decrease the efficacy of calcipotriol. And about the rotational therapies, this was a 9-year-old child who presented to our clinic, and as you can see, she had stria rubra on her inner thigh. She had psoriasis, and she used to use topical steroids, but she was also in the prepubertal state, so probably not only topical steroids are accused. So we tried to use everything except steroids. We were afraid she may develop stria elsewhere in the body, so we kept having rotational therapy, topical vitamin D, tacrolimus, tazarotene. We even used tar for some times, but the kid really hated its smell. And after 2 years, fortunately, the stria were less apparent with time, but the patient still has psoriasis, and she was shifted to methotrexate soon. Moving to systemic treatment, and starting by methotrexate. As Kelly mentioned, it is the most commonly used systemic drug for moderate to severe psoriasis worldwide. We use it in different types of psoriasis. Who has experience of decades with methotrexate, it's effective, well-tolerated, cost-effective, and the doses are weekly, and also it has the usefulness of being effective in psoriatic arthritis. Subcutaneous route has less GIT side effects, better bioavailability and efficacy, but of course all of us prefer the oral route in children. The dose is calculated by weight, and folic acid administration is very important, and studies showed that 6-weekly administration of folic acid is better than a 1-weekly administration because it can lead to less gastrointestinal side effects. Regarding the monitoring, the baseline, we need to do the CBC and liver function test and renal test, and then we need to repeat this after a month, and then afterwards every 3 to 4 months. The route of methotrexate and the dose does not affect this follow-up guidelines. Tuberculosis testing is only recommended in patients who have risk of exposure, and liver biopsy is not indicated for routine monitoring of pediatric patients taking methotrexate, and that's because, to my knowledge, hepatic fibrosis was not reported in pediatric patients receiving methotrexate. Pulmonary function tests are not indicated in patients with pulmonary, or only indicated in patients having pulmonary symptoms. Next, we move to cyclosporin, and in our center, we use cyclosporin a lot for children and adults. It's a short-term crisis management drug. It's a good choice for rapid control of some instances like severe extensive plaque psoriasis, pustular psoriasis, and erythrodermic psoriasis. The dose is calculated by weight, and against our expectation, the children actually has less oral bioavailability and more rapid clearance, so they actually require higher dose. So it's better to start cyclosporin at a higher range of the daily dose spectrum, like 4 or 5 milligram per kg per day, and then once the child is controlled, we can move to less doses. Cyclosporin is mainly well tolerated. The main problem is the limitation of toxicity with the long-term use, particularly, of course, renal toxicity, hypertension, and the risk of lymphoproliferative malignancies. So you should use it only for short time, 6 to 12 months, and some recommendation even for 3 months. And throughout the treatment period, monitoring is very important. And last but not least, gradual tapering is very important because to avoid relapses, and it's better to shift or to bridge with another drug. This was a 12-year-old boy who presented to our clinic. He suddenly stopped methotrexate, and therefore he developed extensive psoriasis, body surface area 80%, and PASI 31.7%. So we started cyclosporin, 200 milligram per day, and after 4 weeks had an excellent response. What we do next, we kept the patient on the same dose of cyclosporin for another month, and then we bridged with acitretin. So we combined acitretin 25 milligram per day. This is a safe combination in children. And afterwards, we started to taper cyclosporin gradually. Last but not least is acitretin. And as we know, acitretin is especially useful in hyperkeratotic sites, palmoplantar pustular psoriasis. It's a little bit slow, so plaque psoriasis usually respond within 2 to 3 months, while pustular psoriasis respond as early as 3 weeks. The main advantage of acitretin, that's not an immunosuppressor, so it's fit well in conditions or situation where we need to give our patient a drug which is not immunosuppressive. It's reported to be used as long as 4 and 6 weeks of age. And here we come to the monitoring of acitretin. Baseline, we need to do liver function tests and lipid profile. Vitamin D was reported here because of patients with ichthyosis who are known to have deficiency of vitamin D. Regarding the skeletal monitoring, we don't need to do routine skeletal monitoring in the form of radiology. So it's enough to follow the gross charts of the child. As long as he's doing well, no problem. If there is any problem, we can move to radiology, and that's because studies showed that bone changes probably don't occur with the long-term use of the low doses we probably use in psoriasis up to 1 milligram per kg per day. In girls, we don't want to use acitretin. Alternatively, we can use isotretinoin, and we use isotretinoin a lot in female in the childbearing period. It's less effective than acitretin, but it can do the job sometime. And we need to monitor the liver function tests and the lipid profile. Lastly, about the conventional therapy is the combination of different conventional therapies. So, of course, topical therapy is added to everything. Acitretin can be combined with everything again, and methotrexate can be combined with phototherapy, acitretin, and biologics. Acitretin can be combined with methotrexate, but it's better to give a low dose of either of them and to follow the liver functions quite well because both have an effect on liver functions. This is an example of 2.5-year-old girl who presented with pustular psoriasis confirmed by biopsy. We managed her by combination of methotrexate, 7.5 milligram per week, combined with acitretin in a low dose, 10 milligram twice weekly, with follow-up of the liver function after 6 weeks. She was doing great. So these combinations are safe in kids. And finally, just want to echo what Kelly mentioned, the treatment decision must be always individualized for each patient. And thank you very much.